Welcome to our video on total urinary incontinence and urethral diverticulum. Let's get started. And here's an overview figure of these topics that we'll cover. And we're going to start with total incontinence. Total incontinence is just what it sounds like. It's continuous urine loss that occurs at all times and in all positions. This can be the result of either a vesicovaginal fistula, more commonly, or a non-functional urethral sphincter. Now, fistulas are aberrant connections between two areas. And in the case of a vesicovaginal fistula, there's a tract that connects the bladder to the vagina so that urine leaks out the vagina instead of being stored by the bladder and then released through the urethra. The vast majority of vesicovaginal fistulas, or fistulas between the bladder and the vagina in the United States, are actually caused by pelvic surgery or pelvic radiotherapy. Childbirth is another risk factor, particularly in developing countries where the labor process is obstructed in some way. And this can lead to necrosis and erosion of the vaginal tissue so that a fistula develops. And the other cause is a non-functional urethral sphincter, and that can be the result of pelvic surgery or nerve damage and infiltrative malignancy. Now, regardless of the actual cause of total incontinence, the patient will present with leakage of urine that is constant and unprovoked. And the urine doesn't uniquely leak with elevated intra-abdominal pressure like you would see in stress incontinence, nor is there intense urge to urinate as in urgency incontinence. And because of that, patients usually report wearing a pad or diaper just to catch the urine. Now here, we're actually just going to focus on the diagnosis of a vesicovaginal fistula, because the specifics for actually diagnosing a non-functional urethral sphincter are beyond the scope of your examinations in medical school, even board exams. Finding urine in the vagina on a pelvic exam with a positive dye test is usually all that's needed to make the diagnosis. And in this dye test, a dye is injected into the bladder to color the urine. Then a tampon is placed in the vagina to see if the dyed urine appears on the tampon or not. And a positive test is when the tampon becomes the color of the dyed urine, which is often blue. And the urinalysis and post-void residual will be normal in these patients. And a definitive diagnosis can be made using a voiding cystourethrogram. Now, in the case of a fistula or a non-functional urethral sphincter, the treatment is typically surgery. Now let's pause real quick and do a brief question. A 45-year-old female with a history of 3 pelvic surgeries complains of continuous urinary leakage. A speculum exam reveals the pooling of a clear liquid in the vagina. What would be seen on a voiding cystourethrogram performed on this patient? So we should start by making a diagnosis before considering what an imaging study might show. So this patient has a history of 3 pelvic surgeries and suffering from continuous urinary leakage. Also, the speculum exam shows the pooling of a clear liquid in the vagina, and that should be making you think of urine. And given her risk factor of multiple pelvic surgeries and the history that she's complaining of, as well as the physical exam findings, you can be fairly confident that she's suffering from total incontinence due to a vesicovaginal fistula. Now here we see an image of a vesicovaginal fistula. Notice that there's a tract connecting the bladder to the vagina, which will result in continuous leakage of urine from the vagina. Now the imaging study that would confirm this diagnosis is a voiding cystourethrogram. And in this test, the patient's bladder is filled with a contrast dye. And then X-ray images of the urinary system are taken as the bladder fills and then as the patient urinates. If contrast dye is found moving from the bladder to the vagina, then the diagnosis of vesicovaginal fistula can be made. And this is what we would expect from the patient described in this question. So in answer to the question, what would be seen on a voiding cystourethrogram? You would see contrast dye moving from the bladder to the vagina. We'll conclude this lecture by briefly discussing one final cause of urinary incontinence that tends to show up on standardized exams. This is the urethral diverticulum. Let's start by showing you this visually. As with any diverticulum, a urethral diverticulum is an outpouching of the mucosa. In this case, the urethral mucosa herniates and abuts against the anterior vaginal wall. And the urinary symptoms that we will describe in the coming slides are the result of this area becoming inflamed and filling with urine. A urethral diverticulum is caused by repeated urethral tissue infections. Specifically, it is the periurethral gland of the anterior vaginal wall that gets infected. And it seems that pelvic trauma and periurethral procedures increase the risk of developing this problem. So what does the patient experience? Well, symptoms include dribbling of urine after voiding, dysuria, purulent discharge, and dyspareunia. So they're going to have pain when urinating, pain when having sex, and they're going to have that dribbling after they're voiding. And if there's infection, then there would be purulent discharge. So what do you see on exam? Well, you may be able to palpate a mass along the anterior vaginal wall, and it's usually tender. Now, the diagnosis of a urethral diverticulum can be made with an MRI of the pelvis. So even with a physical exam and a history that's consistent with a urethral diverticulum, you don't actually make the diagnosis officially until you get an MRI. And then the treatment is actually pretty easy to remember. You surgically excise it. Now I just want to illustrate some ideas visually. So recall the outpouching of the urethral mucosa that occurs in patients with urethral diverticulum, and that's a place for urine to be stored. And as urine is chronically retained within this area, infectious organisms can accumulate. And for that reason, these patients are predisposed to recurrent UTIs, which often manifests as painful urination. Now here's the complete review table summarizing the key points covered in all the lectures of urinary incontinence. So this is here to help you review and be able to quickly compare and contrast these different pathologies. So let's finish this lecture with a board-style question. A 66-year-old Gravida 1 Para 1 presents to the Obgyn Clinic for problems with peeing my pants. Over the last year, she has experienced moments of sudden urinary urgency along with instances in which she wets herself. This initially occurred a few times a month, but is now happening almost every day. She has had 2 urinary tract infections in the past year. Menopause was at age 52. Her 1 pregnancy resulted in an uncomplicated spontaneous vaginal delivery at term. Temperature is 36.7 degrees Celsius. Respiratory rate is 15. Heart rate is 80, and blood pressure is 122/74. On pelvic examination, the vagina appears pale, and there is mild labial retraction. The cough stress test is negative. The remainder of the physical exam is unremarkable, and urinalysis is normal. What would be the preferred initial therapy for this patient? A. Antibiotics. B. Pelvic floor exercises. C. Urethral catheterization. Or D. Vaginal lubricants. Now, to answer this question, we first need to make the correct diagnosis. So this patient has urinary urgency in addition to having 2 UTIs in the past year. And on physical exam, the vagina appears pale and there's mild labial retraction. So given her genital and urinary symptoms, in the context of being postmenopausal, she's most likely suffering from the genitourinary syndrome of menopause. And recall that this is all the result of decreased estrogen levels. So the preferred initial therapy for this diagnosis is choice D, vaginal lubricants. Now, answer choice A is incorrect because antibiotics would be the treatment of choice for a urinary tract infection, but in this patient, the urinalysis was normal. Now, answer choice B is also incorrect. This may have been a tempting answer choice given that she has urinary urgency and pelvic floor exercises can help with that. However, her urgency incontinence seems to be better explained by the genitourinary syndrome of menopause and should be treated accordingly. Also, her cough stress test was negative, which essentially rules out stress incontinence, for which pelvic floor exercises would be the first-line treatment. Now, answer choice C is incorrect as well. And we often use urethral catheterization for patients with overflow incontinence. And here, the patient is struggling from overly frequent urination and not the inability to urinate. So this wouldn't make sense. You don't need a catheter if she's not having trouble urinating. She's just doing it when she doesn't want to. So again, answer choice D, vaginal lubricants, is the correct answer.